Welcome back. This is episode 34 of the MedEdit podcast, your ultimate resource for evidence-based medical education.
And the only podcast where two board certified physicians interview specialists addressing topics the listeners have requested.
In this episode of the MedEdit podcast, we are talking about how to get pregnant and stay pregnant. As I've shared in the past, this topic is deeply personal to me, as 1 in 8 female physicians will experience infertility. We have an amazing guest on the show today, infertility expert and reproductive endocrinology and infertility physician, Dr. Jessica Ryniec. She will help us set up the roadmap for how to navigate sometimes the confusing road of infertility.
And I can see, Dr. Ryniec, why you guys just say REI, because that is a mouthful. But listeners, definitely don't miss the second half of today's episode where we're going to play misinformation, or fact game with Dr. Ryniec. There are just too many incredible myths out there about fertility and infertility. And we want to talk about the truth. We talk about from eating pineapples to French fries. Even seen some things about bone broth. We're going to tackle it all.
This episode is one you are going to want to bookmark and share with your friends. So get ready.
We're your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray. Welcome to the MedEdit podcast. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
All right, difficulty getting pregnant and staying pregnant affects more women than really most people recognize. 13% of women aged 15 to 49 will have difficulty with fertility, according to the CDC. That's a lot. And part of the reason, as Jessica mentioned, this topic is so important to all three of us on this podcast today is there is actually a disproportionately high number of female physicians who struggle with infertility. So it's something that's been important to all of us. Infertility itself is defined as the inability to achieve a pregnancy after at least a year of unprotected sex. There have been studies conducted in the early 2000s that found that, interestingly, rates of infertility actually declined throughout the 1980s and 1990s, and reasons for that decline were kind of unclear. Experts recently suspect that some of the rates of infertility could be related to sexually transmitted infections, which have been on the rise year after year, unfortunately, and those do affect infertility rates. Also, the number of women who are not getting the gynecologic care that they need, which can affect fertility, that number has also dropped. There's not as many women doing that. And lastly, the average age of first-time moms has also been on the rise pretty consistently since they initially saw that drop back in the 90s, and that could also play a role. And because of this, the world of infertility has been rapidly evolving. And I will say the science with REI is truly incredible. It is like mad scientists in a lab from what I have seen and have family members and friends that have told me, which is why we're so excited today to have on the show Dr. Jessica Ryniec, who's going to help us navigate trying to get pregnant and stay pregnant.
Dr. Jessica Ryniec is a double board certified both in obstetrics and gynecology, as well as reproductive endocrinology and infertility. She's a physician for the Colorado Center for Reproductive Medicine, Fertility of Boston. She joined CCRM Boston in 2020 after practicing at the University of Vermont Medical Center in Burlington, Vermont. She received her undergraduate degree from Wake Forest University and her medical degree from Georgetown University School of Medicine in Washington, D.C. During her residency for obstetrics and gynecology, Dr. Ryniec received the Excellence in Female Pelvic Medicine Award and recognition for outstanding accomplishment in women's health. After her residency, she completed her fellowship in reproductive endocrinology and infertility at the University of Vermont Medical Center. And she's got a lot of credentials. I love it. In addition to presenting her research at prestigious medical conferences such as the American Society for Reproductive Medicine and the Society for Reproductive Investigation annual meeting, she has authored several publications for notable peer-reviewed journals, including the American Journal of Obstetrics and Gynecology. She also is super awesome and has a large social media following, dispelling myths about infertility and advocating for women. So all that being said, we always tell you guys about our guests' credentials because they know more than that average influencer on Instagram, okay, or TikTok. They are here to give us this amazing evidence-based medical education, and we are thrilled to have her on our podcast today. Welcome, Dr. Ryniec.
Yeah, thank you so much. I'm really excited to be here. I love the idea of this podcast. I love the episodes that I've watched so far or heard so far. And obviously, this is a topic that's near and dear to my heart as well. And, I would say the prevalence of infertility is even more common than you shared, and even in women physicians. So it's like 1 in 6 worldwide and 1 in 4 in female physicians, which is wild. So
that is amazing.
Yeah. So it's very prevalent, and there are so many myths out there about it. So this is a great conversation I'm excited to have.
Awesome. Thank you. Yes. And so on a personal note, I know we've shared this before. I actually was a patient of CCR, I guess am a patient of CCRM at the location in Denver, Colorado, and they are the reason, the only reason I have my two beautiful baby boys. So I have the absolute utmost respect and admiration from what you are doing and what all your colleagues are doing to help women have families. So big thank you from me.
Yeah, I love that. And I love that you were a part of CCRM.
Awesome. Well, let's start from the beginning for our listeners. Okay, how do you get pregnant? That's a loaded question. All right, so that's a different type of podcast. Okay, so let's be a little more specific, and we will say we know egg meets sperm, but what all has to go right from stage one to a healthy fetus?
So much, basically. There are so many steps that can go wrong or not go right. And that is why the chance of getting pregnant per cycle is really only maximally like around 20 to 25% per cycle, maybe up to 30% if like everything is perfect and you're young and healthy. But really it's kind of in the 20% range. Because of everything that needs to happen to get pregnant. And so not only do you need to ovulate, you need to ovulate a normal egg from a genetics perspective. Your fallopian tubes need to be open and functioning properly. So it's not just a pathway, they actually have some active role in the sperm and egg meeting. Sperm needs to be there, needs to fertilize the egg, and that needs to form a genetically correct embryo that then makes its way into the uterus, which has to be normal and well prepared for implanting an embryo. And then there is pregnancy loss that might come after that, although the majority of pregnancy losses are due to genetic abnormalities. So hopefully we already checked that off earlier in the process. But yeah, I mean, I would say that the general kind of recommendation is to try to have an overall healthy lifestyle, which, getting good sleep, drinking lots of water, moving your body in one way or the other, and knowing your cycle are really important steps to start. Timing intercourse 2 to 3 times in that fertile window is really going to put the sperm and the egg together at the right time, but still so much needs to happen for it to work that most commonly it doesn't happen on the first cycle.
Right. And it sounds like there's a lot of obstacles in the way to get to healthy
Mm-hmm.
fetus stage. So, how long, really, on average, should it for an average person take to get pregnant? And at what point would you be like, okay, there's a
Yeah, so about 85% of people will get pregnant in the first year. That being said, like, I don't love it when people are taking a year. Like, I always wonder if something's going on, if it's taking
right?
longer than that. And so it's really more around like 25 to 30% get pregnant in the first cycle. But about 60% of people are going to get pregnant in their first 3 cycles and about 80% in the first 6. So if it's
Okay.
been more than 6 cycles, my spidey senses are tingling already.
Right.
Um, Another 15%, or sorry, another 5% will get pregnant in that second 6 months. And so when you're young and healthy, it can be reasonable to try for that long, but I'm typically wanting to see people sooner than that. The recommendation is if you're under 35 to come after a year of trying, unless there are other things that have a higher likelihood of infertility, like you're not getting a regular period, you have endometriosis, something that would lead you to have a higher likelihood of infertility. Um, and then it's supposed to be after 6 months if you're over 35. And if you're over 40, you're supposed to head right to a fertility specialist when you're ready to try to get pregnant. I'm always happy to see someone before that timeline. I know people usually get anxious after a few cycles. And so it's
Mhm.
totally appropriate to seek help before that. But that's kind of, I would say the 6 month mark is where the majority of people that are going to get pregnant in that first year have already conceived.
Interesting.
I love having those numbers, though. I think that's what
Yeah.
everybody, including our listeners or even other physicians that are not, REI specialists, really need to know too. Like
Yeah.
when we counsel our patients, we say, okay, how long is too long, or what their goals are, right? Like you said, you're 40 years old. Let's go ahead and just start it off and get you in with a really great reputable, specialist for fertility. But
Yeah, and
also,
also, oh,
Mhm. Go
sorry.
ahead. Go ahead.
I'd also say like the piece where if you have a higher likelihood of infertility, you should see someone sooner, because I'll see people who've seen their OBGYNs even or primary care, and they've said, look, I don't get a period at all, or we've been trying for X amount of months, but something isn't working properly. And they're told, well, you have to wait a year. But then they come and they haven't gotten a period for a whole year. And I'm like, so you haven't been trying that long because you haven't been ovulating.
Right.
So that I think is another really important piece for people to know as well.
That is a really, really good point too. Yeah, definitely helpful. So influencers on the social media like to tout around this idea of, getting their fertility checked, with their doctor ahead of time, well before maybe they even are going to start to try to get pregnant. Maybe they're not even in a relationship yet or that's not even on the horizon, but they've kind of been really set this idea that you need to get this checked. And so from assuming from what I've been listening to or watching those videos, I think they're talking about getting your AMH level checked, that anti-Malarian level checked. Can you tell us a little more about this specific test? Is there other fertility testing they're referring to? Is there a place for this? Is this, just kind of getting people worried unnecessarily? What's going on?
Yeah, so anti-Malarian hormone, or AMH, that is a hormone that's made by the cells that support a developing egg. And so it's a good marker for your egg count or your ovarian reserve, but that's kind of all that it is a marker for. And it's really developed and used by REIs as a way to know or predict how someone might do with fertility treatment, specifically in vitro fertilization. Because that fertility treatment relies on number of eggs. And so we need to kind of know where the reserve is at so that we can guide decision making. And it also helps people know, like, okay, well, if my reserve is low, maybe I want to move on to something like IVF and be a little bit more aggressive sooner rather than later. I think a big misunderstanding about AMH is that it can tell you your fertility, which it can't. Nothing can really tell you your fertility unless you try to get pregnant, and you do or you do not. Certainly, there are tests like the HSG test that could tell you that you can't get pregnant if your tubes are blocked, or a semen analysis that could tell you that you can't get pregnant if there's no sperm. So there are some tests that can tell you, like, hey, this isn't going to happen. But AMH is tricky because people with a high AMH might have infertility, and people with a low AMH might have no problem whatsoever getting pregnant. And that's because when you're ovulating, you are only ovulating one egg at a time. So it does not matter whether you have a million eggs or 100 eggs. Everything depends on that one egg meeting the sperm and doing all of the things that it needs to do. But it is important from an IVF perspective, where we need to get many eggs to have success. So that's kind of, I think, one of the main issues with that. Now, I do like AMH testing with that counseling. For people who know that they're not ready to become parents right now and think that they want to do something like fertility preservation, I think that that's really helpful in planning whether or not that would be something that's valuable to them. It might just end up being valuable whether you do the testing or not, right? Like, even if I get a patient who has a high level, they know that they're not going to have kids for another 5-6 years. Or if they know that they have endometriosis and there's a likelihood that they might need fertility treatment later on, doing egg freezing is like a nice head start. And so AMH testing is really helpful from that perspective. But it can't tell you the whole story.
I think that's a really good point. And I can speak to that one personally. Like I had a high AMH level, but I had endometriosis. And so the AMH stuff was not helpful for fertility reasons because that wasn't very successful,
Yeah.
but it was very helpful to make that IVF be successful. So I think that's a really good caveat. And so likely getting this ordered just randomly online, because I have seen some places that will do it and then they don't have the
Mhm.
follow-up counseling, would be the bigger problem, right? Going to an
Yeah.
REI and having that conversation would probably be your best bet. If you genuinely have concerns or worried about it, make an appointment, go talk to them, ask them if that's a good fit for you at that point in time. And then you can get the counseling. What does it mean afterwards? Because I do know people who have had really low AMHs and they got pregnant naturally. So
Mhm.
there's a lot of caveats to that for sure.
Absolutely. Absolutely.
And I'm sure one of the questions that most people listening to probably have are, what are actually the most common causes of infertility in women that you see?
Yeah. So I think breaking it down specifically to women, so it's about 40% female infertility, 40% male infertility, which I know, we'll talk about, and about 20% both. So, pretty equal contribution. From the female side of things, it's really anything that can impact that chain of events that has to happen. And so one of the most common is actually ovulatory dysfunction. And that can come either from the brain or from the ovaries. So polycystic ovarian syndrome is a really common ovulatory dysfunction. Functional hypothalamic amenorrhea, which usually comes from the brain. So those are like over-exercising, under-eating, low body weight is another cause of ovulatory dysfunction. Others are things like premature ovarian insufficiency, or formerly known premature menopause or ovarian failure. But mainly, thing that ties those things together is not ovulating, so no egg. Then there's anatomy. So fallopian tubes, important piece of getting from the ovary inside the uterus. And there can be complete blockage of the fallopian tubes, or they can just be acting a little bit dysfunctionally. And then the other parts of the anatomy are things inside the cavity of the uterus. So like the overall shape of the uterus,
Polyps,
fibroids, scar tissue, all of those can impact ability to get pregnant. Other than those two things, which are kind of more of the more common ones, there's other endocrine factors. So thyroid, prolactin, vitamin D is starting to be understood. I wouldn't say it's like probably not a sole issue there, but I do see vitamin D being involved a lot, and especially with miscarriage. And then endometriosis is another huge one. And we have kind of an unexplained category, which doesn't mean that there's nothing there, just that the tests aren't showing what it is. Yeah. And oftentimes that's endometriosis.
Frustrating.
Yeah, interesting. And I'm glad that, we're going to talk about, and we brought up the 40% male factor, because I do feel like a lot of times infertility is a burden and a cross that women carry a lot as a stigma, more so than men. Like if you couldn't get a successful pregnancy, it's the woman's fault, like from a society standpoint. So let's talk about the guys. We said they're 40% plus maybe that extra 20 combo percent is contributing. What male factors do you usually see that contribute to infertility?
Yeah, so mostly comes from abnormalities of the semen analysis, the sperm itself. And there can be a range of factors that can impact it, most commonly unidentified or idiopathic. But there are genetic conditions that are associated, like cystic fibrosis or Klinefelter syndrome. There are endocrine issues. So for someone with uncontrolled diabetes or things like that, that can impact infection. Testicular or groin injury is a big one from like a history of that perspective. Infection really like mumps when you were a child. Kind of some other kind of random, silly things that I'm always asking people, like mumps, what are you talking about? Which isn't super common an answer that I get, but something that can cause infertility in men. And then I would say, undescended testicle, problems with ejaculation or erection, other kind of factors like that. And a big one that I'm seeing recently is testosterone use.
Yes, I have seen that too.
Wow.
People are talking about that because you can get there any testosterone, any little corner now. Like, men are like, I'm feeling a little tired, and they're, 28 years old, and they're like, I'm tired. So my testosterone's low. Someone's inappropriately checked their testosterone and some not correct timing and all sorts of stuff, and said, oh, it's low, and we'll give you injections and stuff. So I have heard that too. Very interesting.
Yeah, and I don't think they're getting the counseling. They're not getting the counseling that's going to stop sperm production, which is one of the reasons, just in general, why like just checking hormones is not necessarily recommended.
Oh, yes. Please say that louder. Yeah, just randomly checking hormones is not recommended. Yes. Thank you. I get asked this at least once a day of all ranges of women. They say, can you just check my hormones? And I'm like, well, we could check your thyroid hormone, if it's appropriate, like in a perimenopausal, postmenopausal type concern, maybe an FSH, but like, no. Check my estrogen, my progesterone, and testosterone. And so trying to explain why that's not the best approach, it can be really frustrating sometimes, both for the patient too, because they're like, well, I could go get it checked at the Any Lab Test Now or Quest, and they can do it for me. And it's the need to interpret it by somebody who's an actual professional in that area, which isn't even me. It's going to be an REI professional is really important. So this next topic can be a triggering subject, but What about recurrent miscarriage? Statistics show infertility after miscarriage is a devastating condition affecting, from what our statistics showed, about 1% to 2% of women. Sadly, I was in that category, and I actually have close friends who have battled recurrent miscarriages. So, what causes the recurrent miscarriage? What would be defined as, here we're saying 3 or more consecutive spontaneous miscarriages? And what fertility treatments are available for somebody with recurrent miscarriage?
Yeah, so recurrent pregnancy loss, yes, technically is defined as three, although recently our national societies are recommending evaluation after two
Oh,
consecutive losses, which is good. I think that's what I've always done, but it's nice to have some support for that
mhm.
because nobody wants to have recurrent miscarriages.
Right.
You can't say like, well, just go have a third one before I'm going to do some
Yes.
evaluation. I think part of it there is that unfortunately, about 50% of the time, we don't get an answer for what's going on. And so, it's tough. There's not necessarily going to be an answer for everyone, but sometimes just knowing and ruling things out and then having that support is enough. And so when it comes to recurrent loss, still genetics can be a big component, like random aneuploidy, oftentimes age-related aneuploidy. So when it's a 43-year-old that has recurrent pregnancy loss, it's different than a 23-year-old potentially having recurrent pregnancy loss. Um, and there's also more commonly a specific kind of genetic abnormality, which would be called a translocation with recurrent loss. And so translocation basically rearrangement of your own chromosomes such that when you pass them on, there's a higher likelihood that the embryo would not have the correct number of chromosomes. And so that would be unrelated to age. So that's something that we see more commonly with recurrent loss. There's also autoimmune, and I think this is one area that we absolutely need way more research on.
Yeah.
And that's, I think, a big area of misinformation on the internet about the immune system and reproduction, which I'm sure is so involved, but we just don't have a lot of info about it. Um, but we do know, in particular, antiphospholipid syndrome, for example,
Yeah.
which is an autoimmune blood clotting disorder. Thyroid antibodies can impact pregnancy and pregnancy loss. So we look for those certain things. And then the last main category of things that can cause recurrent loss is that shape of the uterus. So things like unicornuate uterus, septums, bicornuate uterus, or things that are inside the uterus, like a fibroid or a polyp or scar tissue.
So, what are the first steps in seeking help with infertility if it is taking longer than expected?
So I love when people come to see me. Certainly,
Mhm.
there are not REIs available or readily available everywhere. And so, general OBGYN could be a good first step for people. And that might be the best first step for people if there's not an REI available. If you know that there's higher likelihood, though, that you're going to need a full fertility evaluation and fertility treatment, an REI would be a good first step if you have one in the area. Um, a lot of times, my local OBGYNs will do the testing, and that is super helpful because they already have it and we can kind of go through things. But um, either one could be a good first step. And really, it's kind of doing a really good medical history to kind of identify what things might be a particular issue for you specifically, and then kind of doing general fertility testing.
So, what kind, you say testing. So, what kind of testing would you expect in that workup for infertility?
Yeah, so I usually say there's about four main areas that we look at. And one of them is that ovarian reserve testing, which again doesn't cause infertility, but helps us guide treatment making decisions. So we do that AMH hormone. We typically will do a panel of hormones on the third day of your period. That's a hormone called follicle stimulating hormone, or FSH, plus estrogen. And those ones kind of give me a more functional look at the reserve, so how the brain and ovaries are talking to each other. And then we also will do an ultrasound and look directly at the ovaries to kind of see what your follicles look like. And follicles are developing eggs. So, three ways to look at the reserve. The second part is some other reproductive hormones and just general pre pregnancy testing. So, thyroid, prolactin, vitamin D, pre pregnancy testing like blood counts, infectious disease testing, genetic carrier screening, I think is important for people that are planning a pregnancy, making sure you're immune to things like the measles, perhaps,
Mhm.
and chickenpox and rubella. Um, and then the third part is anatomy. So that's looking at the fallopian tubes. That test, a few different ways to look at that. So you can do an HSG, hysterosalpingogram, that's an X-ray with dye. I prefer doing something called a saline ultrasound. It's a little bit different, but also a little less uncomfortable tends to be than the HSG. Tells us the same information. Unless there's a high likelihood of tubal factor, then I would do the HSG, but the saline ultrasound can give us some pretty good info too. And then the fourth part is for male factor, and that would be a semen analysis.
Which is probably no guys readily signing up for that, but that sounds like the easiest thing out of all of
Yeah.
that list actually right there.
Yeah,
Yep.
exactly.
If I
It's
had
like,
to pick one test, I would pick the
yeah.
semen analysis.
Yeah.
It's like you're getting 15 tubes of blood drawn, and then I
Yeah.
need you to do a semen sample, please.
Yeah.
Like, I'm sure it's not
You'll
exactly
be
like that,
okay.
but that's kind of what it sounds like. So, okay, so
Absolutely.
we've talked about what's normal, when to be concerned about abnormal, who you should see initially and what that workup will look like. Let's kind of jump a little bit to management or intervention options. So can you give us just kind of an overview of maybe what some of those management or interventions you may recommend for a patient when they come to see you or an REI specialist?
Sure, absolutely. There's really a few main pathways. Some of it is treating subtle other issues, so like thyroid, elevated prolactin, things like that. Sometimes people need surgery, like if there's a high likelihood of endometriosis or their tubes are blocked, although IVF is a good option for that too. But the few main pathways, like specifically from a more directly fertility related, are ovulation induction. And that can be done with oral medication or injectable medications. Most commonly these days, we're using oral medications more frequently because the injectables have a high risk of multiples and higher order multiples and, you know, like 8 octuplets and things like that. So we don't like to do that anymore. So it's typically oral medications like Clomid and Letrozole. Um, and that can either be with timed intercourse if it's solely an ovulatory issue, like you're not ovulating and everything else looks good, oral medication might be all you need. If it's a little bit unexplained, or if there's mild male factor or, even moderate male factor, intrauterine insemination might be beneficial for that. And that basically is when we wash and prep the sperm and put it high up the uterus, high up inside the uterus with a catheter to get it closer to the egg at the time of ovulation. And then there's in vitro fertilization or IVF. And that is when you take injectable hormones to stimulate multiple eggs to grow. We take the eggs out of the body and make embryos in the lab. And then later on, we put them back in the body for an embryo transfer.
So let's say you did it. Let's say you got your first positive pregnancy test at home. How do we make this stick? With 1 in 4 women reporting a history of miscarriage, there's a lot of initial anxiety for that first trimester. There's a lot of things online, but what are some things we should or should not do that actually will affect the rate of miscarriage?
Absolutely. And this is kind of a tough one because the most common cause of loss is genetics. And that's unfortunately out of our control, but also goes to show like miscarriage is not your fault. And if
Right.
anyone makes you feel that way, like they're just totally out of touch with what's reality.
Yeah.
So,
Mhm.
um, makes you feel better in that way, although not, because how do you control it then? And really it's kind of going back to those overall healthy lifestyle factors. So making sure you're getting good sleep, drinking lots of water, moving your body in some way, and then an overall kind of healthy diet and lifestyle, and avoiding things like smoking, drinking alcohol at all in pregnancy, but in moderation while you're trying. Caffeine, limiting that in early pregnancy. Still can have your cup of coffee a day, but you wouldn't want to be having much more than 200 milligrams of caffeine. And, making sure you're not putting yourself in a high risk of like trauma. But other than that, there's a lot that's out of our control from that perspective.
Yeah. It's like I said, it's a miracle. It sounds like from conception to delivery that things go right when they do.
Mm-hmm.
It just makes you so much
Mhm.
more thankful for when that does happen because man,
Mhm.
it is a journey. It is a journey to get there. And I know we had talked about this at the very beginning of the episode about some of those infertility rates overall kind of somewhat on the rise. What are in your field, people in the know, what are their suspicions on maybe why we're seeing that?
I think part of it is age. I think that people are putting off having children until a later age. At this point, women are focusing on career or other things and going to school. So I think a little bit of that is involved, but I think a lot of other things too. It's tough to maybe put a finger on. They found that for women physicians, like it's separate than just age and
Yeah.
delaying childbearing, so there's something else that's going on. Maybe stress, for physicians, maybe like years of not taking care of ourselves, but
Right.
it could very well be a lot of environmental things as well. We read about all of the microplastics and the pollutants and endocrine disruptors. So all of that certainly can be playing a role.
Yeah, I'm sure it has somewhat to do with the other epidemics we've talked about kind of along the same
Hmm.
timeline, right? With obesity and
Mhm.
whatever's led to all of those crises that we've seen. I mean, I'm sure there's some sort of correlation to what
Absolutely.
phenomenons that have led to that probably as well that we just don't understand. So, okay, very interesting, very helpful.
Yeah.
And this is the perfect transition into part two where we play fact or miss, which is for misinformation, which is great because I definitely need this myself. Misinformation for REI will not lie. I'm one of those people who thinks REI and thinks Octomom. That's like that's it. That's the only thing that happens. You end up with 8 babies. You're Kate,
Hmm.
Thank goodness it
whatever.
doesn't.
I mean, you saw those shows when we were like
Yeah,
younger, right?
yeah,
And you're like, everybody gets REI, ends
yeah,
up having 5 to 10 children, like, which is not true.
Hmm.
So I'm glad we're doing this.
yeah,
Yeah, it's
absolutely, yeah.
actually like poor form for that to happen these days.
100%. Yeah,
Yeah.
exactly. Like that's not you should not be doing that. But I mean, watching like what was it, 8 Kate plus 8 or something
Uh-huh.
growing up and like
Hmm.
Octomom was like, well, this is what happens. You get REI or you get help, you get REI and you end up with a lot of children. So I'm
Absolutely.
glad we're doing this.
Yeah.
Yeah. So, to play this game, we read you comments from non medical social media influencers. And if it's medical, it's generally not, let's just say it's not evidence based, especially our REI physician recommended. But you get to tell us if this is actually a fact about infertility or just a bunch of misinformation.
Sounds good.
All right, number one, which I'm sure you've heard a million times, we've heard a million times, but the number one is using birth control when you're younger or not, but especially when you're younger,
Mhm.
leads to long-term infertility. Fact or
So
miss?
this is miss. Other than the fact that if you're using birth control for a long time, you are therefore getting older, and
True.
age can impact fertility. But the birth control itself does not impact fertility. The only one that potentially has a very short-term impact on fertility is Depo-Provera. But after about 18 months, if you're having issues, that tends to wear off. So there's no long-term impacts of any birth control.
I think that is so important because that is one that we get asked about all of the time. All
Hmm.
of the time. Yeah.
Absolutely. Yeah.
So, number two, eating yams increases the chance of twins. Is this a fact
Oh.
or miss?
So probably miss as well. This is based on a particularly high twin rate in the Yoruba population in Nigeria. And
Mm.
they attribute it or have a cultural belief that it's related to the yams that they eat. Now, yams do have a phytoestrogens, and so there's kind of like some biologic plausibility, but a lot of other people eat a lot of yams and they do not have a higher likelihood. So it's more likely something genetic that they have a higher likelihood of ovulating more than one eggs because it's specifically fraternal twins, not identical twins. So
Yeah.
it's probably something that runs in their genetics that they're more likely to do that. And then they have a higher likelihood, not the yams.
Oh,
Mm.
I love knowing that. That's like the
Yeah.
coolest bit of like medical
Well, it reminds
Yeah.
me, I don't know if you guys
trivia.
ever watched the Sex and the City movie where they traveled overseas and Samantha's hormones got confiscated and she started eating
Oh,
like a
yes.
million yams because she was
I
trying
do
to get
remember.
Mhm.
estrogen. Like that's what it reminds me of.
Oh,
So
that's so
she's
true.
even she had heard that, and it was not for
Yep.
fertility reasons. But this next one makes me laugh, not because of what it is, because I literally have had a patient that I saw as a med student who told me this.
Mhm.
But the next one is number 3: swallowing semen can boost fertility.
That's another misinformation. And we can thank Kourtney Kardashian for that
Yeah.
one, who claimed she
Yes.
claimed that her doctor told her she needed to do that
Mhm.
4 times a week, which is
Oh yes.
wild how you would know exactly what the exposure would need. But misinformation that has been pretty well debunked, although there are some studies about that and other pregnancy complications, particularly preeclampsia, that have some interesting information, but it is not going to help you get pregnant.
Don't let anybody know that. Okay.
I know.
No, that's interesting. Okay. All right. Here's our last one. So, number 4, can certain sexual positions increase the chance of conception? Is that a fact or a miss?
It's a myth. So I tell people whatever they enjoy and they're wanting to do, go for it, but no particular position. And that's important too, because you don't have to be lying with your legs up in the air afterwards to have a successful pregnancy.
Yeah, I'm sure we've all been told that personally as
Mm-hmm.
well as professionally. Like, well, if you want to get pregnant, you just need to be in this position. Or if you want a boy or you want a girl, you've got to be in this position for that to happen.
Absolutely.
I was definitely told that. So
Yep.
Awesome. Well, see, this is why I love this game. It's impossible to sort fact and fiction on the internet alone. So that's why we have great experts like Dr. Ryniec here today. And thank you again for joining us. Your insight is truly invaluable, and we really appreciate it.
Yeah, thank you so much for having me. And I love talking about this. So this has been great.
We love it. We might have to have you come back again and talk about the preeclampsia information too.
Let's do a follow-up when that gets clarified some more.
Or more
Seriously.
Yeah, exactly.
So that's all for the episode of the MedEdit podcast. Don't forget, if you're a listener claiming CME credit, please look in the show notes for instructions.
And for all of our listeners, thank you for tuning in as always. Please like, subscribe, follow us on socials, and share the episode. Let us know what other topics you're interested in through our Instagram or TikTok, and stay tuned for the next one.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.